In this last section, we're going to talk about neoplastic diseases of the colon. These include two major cancers, carcinoid tumor and adenocarcinoma. The carcinoid tumor they love to test about because it's a neuroendocrine tumor most often found in the small intestine of the appendix. It's a malignant tumor, but it's usually low grade. Once it metastasizes to the liver, it produces a syndrome called the carcinoid syndrome, which includes cutaneous flushing, diarrhea, sometimes headaches, bronchospasm and wheezing, and tricuspid regurgitation or pulmonic stenosis. Remember, the carcinoid syndrome is a result of excessive amounts of serotonin release. This can be detected in a 24-hour measurement of the urine of 5-HIAA, which is a breakdown product of serotonin. Adenocarcinoma is what we'll spend the remainder of the talk talking about. Remember, adenocarcinoma is the most common carcinoma in the entire GI tract. The colon is no different. Colorectal cancer adenocarcinoma is the third most common cancer in the United States. That is why the boards love to test about adenocarcinoma of the colon. Usually it's located in the rectosigmoid region, but can also be found in other parts of the colon. Risk factors for colon cancer include age greater than 50, cigarette smoking, and ulcerative colitis. Remember, ulcerative colitis is a strong risk factor for colon cancer. Here's a picture that shows colon cancer throughout the GI tract. Notice different areas of the GI tract which can arise with colon cancer. Typically, left-sided lesions, seen near the rectum, result in an obstructive type pattern. Patients can typically present with pencil-thin-like stools when cancers are located here. Cancers on the right side, near the cecum or the ascending colon, usually present with bleeding and or iron deficiency anemia. Rarely do colorectal cancers present with overt GI bleeding or hemorrhage. Typically, the history is that of a patient with occult GI bleeding or iron deficiency anemia resulting from chronic blood loss. Family history is an important risk factor for colon cancer. Remember, there are 3 genetic syndromes associated with colon cancer. FAP, which includes Gardner syndrome and Turcot syndrome, HNPCC, also known as Lynch syndrome, and Peutz-Jeghers syndrome are all risk factors for adenocarcinoma of the GI tract. FAP syndrome is an autosomal dominant mutation in the APC gene, found on chromosome 5. Patients with the syndrome develop thousands of adenomatous polyps, usually at a very early age, some of which eventually become malignant. These patients have a 100% chance of developing colon cancer by the age of 40. Gardner syndrome is FAP with the association of benign tumors such as osteomas, fibromas, or epidermal inclusion cysts. Turcot syndrome is FAP syndrome plus CNS tumors. So Gardner syndrome and Turcot syndrome are subsets of FAP. Remember, again, FAP is a defect in APC gene and is an autosomal dominant. These patients almost always develop colon cancer, and thus we always recommend total proctocolectomy. Again, that's the removal of the entire colon and rectum. HNPCC, also known as Lynch syndrome, is also an autosomal dominant defect in DNA repair genes. These patients also demonstrate an increased risk of colon cancer, endometrial cancer, and ovarian cancer at a young age. These patients typically have the history of 3-2-1. That is, at least 3 family members affected, 2 generations, of which 1 patient is a first-degree relative. Peutz-Jeghers syndrome is also an autosomal dominant syndrome in which patients develop multiple hamartomatous non-neoplastic polyps, usually arising in the small intestine. Remember, Peutz-Jeghers syndrome has hamartomatous polyps which are not neoplastic. These patients are not at risk for adenocarcinoma of the colon, but are at risk for adenocarcinomas in other parts of the GI tract. The molecular pathogenesis includes APC, KRAS, DCC, and P53 mutations. The precursor lesion is usually an adenoma, which results from an overgrowth of dysplastic epithelium in 1 or 3 morphologies. A tubular adenoma can either be pedunculated or it can be sessile. A villous adenoma can be large and sessile. A tubulovillous adenoma is a combination of the two. Anytime you see villous adenoma or tubulovillous adenoma, these are very strongly dysplastic lesions and suggest early carcinoma formation. Here's a picture showing polyps in the colon. Remember, polyps which are adenomatous or tubulovillous are at risk for growing into adenocarcinoma. Again, tubular adenomas are pre-malignant conditions. Risk factors for the malignant transformation of adenomas include multiple adenomas, size greater than 2 centimeters, villus morphology, or the degree of dysplasia. Severity is measured by the degree of invasion using the Duke staging system, A, being limited to the mucosa, B, extending into the submucosa, C, extending to the serosa, and D, metastatic disease. Here's a diagram showing the Duke staging system. Metastasis occurs when tumor grows into the lymph node and spreads via the blood vessels. Lymphatic spread can spread to local lymph nodes or spread to distant sites. Remember, the liver is the first site of metastasis of adenocarcinoma of the colon. Again, colon cancer goes straight to the liver. Prognosis is dependent on stage. The deeper the invasion, the worse the prognosis. Here's a picture of a tubular adenoma with a stalk. Notice the dysplastic adenomatous tissue. Here's a picture of cecal adenocarcinoma. Notice at the bottom left corner you have this fungating mass present in the cecum. Again, this is a slide showing the differences between right-sided and left-sided lesions. Usually, right-sided lesions present with occult blood loss and occasionally iron deficiency anemia. Left-sided lesions, that is lesions closer to the rectum, show change in bile habits, typically because these are obstructing tumors. They grow large and obstruct, resulting in pencil-thin stools or decreased caliber in stools. Now for the Step 1 simulator questions. An 8-week-old infant has been feeding poorly, and the mother notices that the majority of the milk the baby ingests is forcefully vomited soon after feeding. The baby was delivered at term and has no other abnormalities. The best explanation for the feeding problem is tracheoesophageal fistula, acute gastritis, pyloric stenosis, Meckel's diverticulum, and duodenal atresia. In this case, with the patient with projectile vomiting, described as forceful vomiting soon after feeding, you would first think about a pyloric stenosis. Again, pyloric stenosis would be the lesion that would best describe this infant. A 49-year-old woman presents with abdominal pain and diarrhea. The stool specimen shows blood and mucus, but is negative for ova and parasites. Similar attacks have occurred over the past 10 years. Colonoscopy shows uninterrupted mucosal inflammation and ulcers throughout the colon. This patient is at high risk for developing A, adenocarcinoma, B, carcinoid tumors, C, malabsorption, D, pseudomembranous colitis, and E, angiodysplasia. This patient is at risk for developing adenocarcinoma. Remember, this patient has ulcerative colitis, as described by uninterrupted mucosal inflammation and ulcers throughout the colon. If it were interrupted, you would think about Crohn's disease. The fact that the patient is negative for ova and parasites, and the fact that the patient has had these symptoms for greater than 10 years, rules out infectious colitis. A 60-year-old man undergoes excision of an obstruction of a large intestine. Which of the following microscopic features in the obstructing lesion most strongly suggests malignant growth? Focal areas of necrosis and inflammation, formation of new vascular channels and hemorrhage, hemosiderin-laden macrophages, mucin within and outside epithelial cells, sheets and cords of epithelial cells in the serosal layer. Sheets and cords of epithelial cells in the serosal layer would suggest abnormalities in the architecture of the cells, and this would suggest malignant growth. And this concludes the GI pathophysiology section